longue de l'année, 21 juin, le solstice d'été. It's also the beginning of summer today, so I hope that everyone has a great summer. We thought it would be important to get together one last time before the summer. Hopefully, it won't be necessary to do it again in July or August, but we'll see. One never knows. Alors, je veux débuter en remerciant tout le monde pour tout le travail accompli au cours de cet hiver et de ce printemps qui s'achève. Actually, over the last 2 years, we've been more than 2 years now. It's 2 years and 3 months. We've been very, very busy. We've been taking care of our patients. Et en même temps, je vous encourage tous à prendre des vacances cet été. Je sais qu'on a fait des efforts pour que tout le monde puisse avoir des vacances. Donc, je vous souhaite de passer de très bonnes vacances. On va aller à l'ordre du jour pour notre webinaire, qui est la prochaine diapo. OK, la voilà. Prochaine diapo. Voilà. Alors, on va commencer avec Dr. Claudine Lamar. Je vais donner quelques informations générales. Puis, Dr. Lamar will be giving you the MUHC clinical update on what's happening this summer. And then I would like to thank Dr. Ruben, who accepted on a very, very short notice to prepare a presentation, an update on the pandemic. Thank you very much, Earl. Puis par la suite, comme d'habitude, Mme Alfonso va animer la session de questions-réponses. Et il y aura plusieurs personnes qui vont tenter de répondre à vos questions. So, next slide, please. On commence avec les bonnes nouvelles. Alors, on a reçu tout récemment la reconnaissance complète de ce qu'on avait demandé pour nos résidents ventilo-assistés à Camille Lefebvre. Ça va devenir une unité spécialisée aiguë qui va être située dans un centre d'hébergement. Il va y avoir des ajouts de ressources, aussi bien du côté équipe de soins, nursing, mais aussi du point de vue médical, ça va être plus facile d'assurer la couverture avec cette reconnaissance. On est heureux parce que c'est un dossier qui remontait à l'automne 2019 et qui a finalement été réglé il y a quelques semaines. Situation dans les urgences. Demain, il devrait y avoir dans la presse, demain ou jeudi, un reportage assez fouillé sur la situation dans notre salle d'urgence. One of their journalists, Madame Marianne Lacourcière, she spent 2 or 3 days, I think, in our ER at the Glen site on the adult side, at the RVH emergency room. And she spoke to many people. We wanted, when they requested permission to come in for this piece, we wanted to explain the situation that we have to live with at the Royal Victoria, the systemic causes, and that are part of the problem at the Royal Vic, which doesn't have very good statistics. So I think it should come out. Basically, excusez-moi. Sorry. Je suis branché parce qu'autrement, on va perdre. OK. Am I back? Am I online, Martine? Est-ce que je suis en ligne, là?
On vous entend bien, Dr. Feller.
OK, parfait. Excellent, excellent. Donc, moi, j'ai perdu la slide, là, mais ça va probablement revenir. Alors, on voulait expliquer la situation, puis aussi nous assurer qu'on mettait au devant, si vous voulez, notre orientation de se recentrer sur notre mission tertiaire et quaternaire. At the present moment, we're still getting many general cases, walk-in patients to start with, but at the same time, ambulances with general cases that could and should be seen in community hospitals. We also get our share of elderlies, and we're saying that for general conditions, des pertes d'autonomie, par exemple, ces personnes-là devraient être prises en charge par les centres hospitaliers dans la communauté, autres que les CHU. C'est la même situation pour le CHUM, pour nous. Alors, c'est ce qu'on a essayé de faire transparaître dans le reportage. So we'll see the results. Of course, when you meet with a journalist, you never know how it's going to come out, but we'll see how it comes out. It's going to be a bit later this week, maybe tomorrow, or maybe Thursday. So about 2 weeks ago, we got a letter from the department heads of all the ERs in Quebec. It was sent to all the PDG. And Of course, they are worried because the ERs are extremely busy, not only at the MUHC, but all over Quebec. And I was also watching TV last night. It's the same situation in Ontario and in many other jurisdictions. Je pense qu'il y a beaucoup de personnes qui ont retardé de consulter durant la pandémie, de crainte d'attraper la maladie à l'hôpital. Je pense que les conditions se sont détériorées. Et donc, je pense qu'on fait face à ça à l'heure actuelle. Puis beaucoup de gens qui consultent, qui étaient inquiets, mais qui n'osaient pas consulter, avec le relâchement des mesures et puis un retour à peu près à la normale dans la vie en société. Je pense que c'est un peu normal que nos urgences soient pleines. Alors, il faut travailler sur la première ligne, sur l'accès à un médecin de famille, mais une première ligne intégrée. Vous allez entendre parler beaucoup de ça. Accès à une première ligne intégrée plutôt qu'un médecin de famille. On était en train de changer l'approche un peu. So obviously, we have to improve that as a society. As well, NSA patients, they shouldn't be staying in our hospital because we do have to take care of our patients who need super specialized care that cannot be provided anywhere else. Relève du leadership. So that's another article that was published in La Presse. I think it's about a week or 10 days ago, and my name was mentioned. Donc, il y avait un article publié sur les changements de gouvernance en termes de leadership dans les différents établissements au Québec. Ça bouge beaucoup. Il y a la génération des baby boomers qui se prépare à prendre sa retraite, à quitter. J'en fais partie. Alors, il était mentionné dans l'article que je serais probablement là jusqu'au mois de décembre, novembre. C'est en effet ce qu'on m'a dit au gouvernement. Je devais quitter l'année dernière. J'ai fait une année supplémentaire parce que je ne voulais pas quitter durant la COVID. Puis, finalement, je devais quitter à la fête du travail, mais on me demande de demeurer en fonction jusqu'à la nomination du nouveau ministre de la Santé qui, lui, va vouloir nommer les nouveaux PDG, entre autres du CHUM et du CUSM. Donc, I'll be with you at least until November, maybe in December, and the search process has already started, not at full speed, I would say, but I think people are showing interest, and I'm really confident that the institution will be able to find my successor, and that it will be really a good situation. Je pense très bien que l'établissement est bien situé. Je termine peut-être avec une note sur les résultats financiers. It's always important to take a look at the bottom line at the end of the year. So this year, we're going to end up the year with a deficit of around $5.5 million out of a total budget which is over $1.5 billion. So it's far lower than 1%. That is usually considered as within acceptable limits. At the same time, out of these 5.5 million, part of the deficit originates from the Research Institute, and part of the deficit originates from our Optilab operations in Abitibi-Témiscamingue. So I think we're well positioned financially for the upcoming years. And also maybe a bit more difficult times that are coming. There might be a recession. I don't want to go into percentages of the odds that we're going to have a recession. I'll leave that to the politicians with inflation and everything. So, but at the present moment, we're well positioned. Prochaine diapo, s'il vous plaît. So, alors, vous savez que le ministère et le gouvernement relèvent tranquillement, graduellement les mesures sanitaires. Elles existent encore dans les hôpitaux, mais vers le 18 juillet, ça devrait être terminé. En tout cas, à l'heure actuelle, on n'est plus financé pour beaucoup de mesures qui étaient financées durant la pandémie. So, we will gradually remove between now and July the 18th the entrance screening with security guards. This is not being financed anymore at the present moment, and it would be a huge cost for the organization. I'd rather use that money to provide care to our patients. Alors, on va continuer. Il va y avoir des pancartes, il va y avoir des communications, un message très important pour tout le monde. You have to wash your hands, wear a mask, and if you have symptoms, don't show up, because we still have a couple of cases, a certain number of cases every day of employees who test positive. Alors, si vous êtes symptomatique, ne venez pas travailler. Of course, if we get a seventh wave, we would reinstitute the entrance screening if necessary, because safety of our patients and of our staff comes first. Voilà. Je vais maintenant laisser la parole à notre nouvelle directrice des services professionnels, qu'il me fait plaisir de vous présenter. Je ne crois pas qu'elle a pris la parole durant les webinaires. Peut-être la prochaine diapo. Alors, Dr. Claudine Lamarre, elle a été nommée DSP déjà, c'était au conseil d'administration du mois de mai. Dr. Lamarre, c'est un médecin qui a fait son cours de médecine à l'Université McGill. She went to McGill Medical School, and then she went to University of Montreal to do family medicine and surgery. So she's a surgeon by trade, and she worked in Montérégie. And now she has oriented her career towards administration and management of hospital management. She holds a master's degree in hospital administration from l'École de santé publique de l'Université de Montréal. So I'll leave it to Dr. Lamarre to give you an update on what's going on the clinical side at the MUHC. Dr. Lamarre, je vous laisse la parole.
Merci, Dr. Feller. So I wanted to say a few words before I begin on the update, on the clinical update. And Dr. Feller introduced me well, thank you. For me, I'm coming back to my roots here, coming at the MUHC. As you mentioned, I'm a McGill graduate, and I have most of my working years spent as a general surgeon on the South Shore in CIS Montérégie West. I recently turned to management. I did an internship here, and the reason I chose the MUHC was because I was attracted, I guess, as many of you were, because of the academic excellence of the MUHC. So after I finished my internship, I worked as an associate DPS, and I'd like to thank Dr. Eva Sidorovich, who in the past months has been a mentor for me, and I would like to take also this opportunity to wish her all the best for the coming years and her new projects. So I've decided to stay on at the MUHC after my internship and to accept the challenge of being the new DPS here. Mostly, as I said, I was attracted because of the academic component and the excellence of the care that we give. But what's really made me stay and interested in staying is the strength of its people, and that I can witness every day at every level of the organization. So one thing that I'd like to say before I move on is please feel free to come introduce yourself to me. If you meet me in the corridors or in the elevators, you now have a face that you can relate with. So I'm gonna be glad to introduce myself at that time. So I'll take the next slide. So this is a brief plan of my presentation. I'll speak about some changes at the DPS office. I'll speak about current clinical activities. I have some graphs to show you about wait lists. I have a brief slide also about the IV contrast shortage in radiology. It's a problem not only at the MUHC, but in the province, and a bit about the priorities in the next few months. So next slide, please. So first about the DPS office, maybe you're not all aware, but we have Sophie Dussault, who's been named as assistant to the DPS, who started a few months ago. We also have some new people in admin support, Nawal and Rabet being one of them. And eventually there will be also new associate DPS for adult sites. Bob Barnes is there to support us on the pediatric side. He's continuing on. As well, in terms of people that are staying with us, Maryse Godin, who I'd like to say is now to congratulate because she's been named Associate Director for mental health and the emergency department. For her functions in the mental health mission, she works with call-in team of the DSM, and the emergency department is with the DPS. There's also Carole Lapierre, who I think many of you know, Michel Picard, André Bonici, I'd like to name also Nancy Branco, Michel Aboissali, and France Paquet. They're all managers that work in the DPS office. And of course, there are many others. I can't name everyone here at this time. I'd also like to take the opportunity to tell everyone that Madame Christine Bouchard has also been named Associate Director in Oncology. This is not part of the DPS office, but we're still very happy for her that she's received this nomination. So next slide. Okay, I'm going to speak a little bit about the current situation, which I think we've been facing the COVID crisis in the past few years. It was a challenge that has been very difficult, but I think the MUHC has really taken this challenge with great success. Now we have another challenge. It might be a little bit more insidious because it concerns staffing, and it's the direct result, I think, of the pandemic. It's not the only cause, but it's one of the causes. And this is impacting our clinical activities. In terms of clinical impacts, definitely the nursing, and Alain Biron is here with us. The RTs are having, we're having shortage problems. We also see it in medical imaging technicians and in the laboratory. So there are just a few examples of impacts. In terms of bed closures, about little less than 10% of our budgeted beds that are being closed from week to week. The OR closures, we're not able to reach our maximum capacity in the OR, unfortunately. Waiting list, I have a few slides to show you this, and this is obviously we're looking at a point in time, but it's the result of many months of having to take care of COVID patients in priority. Night coverage for the blood bank is also one impact. I was speaking about lab technicians earlier. So unfortunately, the private sector is very attractive. So that's one of the reasons why it's difficult to staff our lab, especially at night. So this is something that's looked at very closely to try to help keep our personnel to cover the nights. And another impact, I think you've all been aware that at Lachine, the situation has been difficult for many months now, and the emergency department is still closed to ambulances at night at the current time. Next slide, please. So these are some examples of wait lists for the OR in terms of number of cases on the wait list. As you can see, the problem is more noticeable at the Glen and the MGH. With a rise in number of cases on the wait lists. The neuro OR and the MCH OR have also increased wait lists that might probably become bigger in the upcoming months as ambulatory clinics and pre-op ramp up the demand. So maybe the graphs don't really give a good picture of what's going on there. So next slide, please. So you can see that there is a noticeable increase in terms of wait list also for the cath lab at the Glen, while the EP lab is sort of more or less stable over the last 3 years. Next slide. And this last slide shows endoscopy and medical imaging, and the 4 bottom graphs show the areas that are of most concern. So you can see that radiology is definitely being hit. We spoke about technicians earlier in imaging. So in terms of the wait for CT scan and ultrasounds, those are difficult. There's a lot of demands, it's making it tough to prioritize exams because every single exam seems to be a top priority. So it's really a difficult exercise that we have to do to try to best accommodate all the requests that are coming. So that's it for this one. Next slide, please. So a few words on the IV contrast shortage you may have heard in the news. This is a contrast that's being used for radiology exams, but also in the cath lab. There are two main suppliers in Quebec. So some hospitals, all of those on the Montreal Island, are affected because they're all supplied by the same plant or the same, yeah, it's GE that supplies the Montreal Hospital. Because of COVID, there was a shutdown in Shanghai that's now finished, but it was closed for long enough that it did affect production and supply. And it takes 6 weeks for a contrast to be shipped and to arrive ready to be used in the hospitals. So since depuis qu'on sait qu'il va y avoir des manques là, au niveau des livraisons par GE, il y a des plans de contingence qui ont été rédigés dans plusieurs hôpitaux, dont le nôtre. Là, Dr. Jeff Shamkovsky et Michel Picard ont travaillé fort là-dessus. Ces plans-là ont été partagés avec les autres hôpitaux qui ont à leur tour partagé les leurs et ainsi qu'avec le ministère. Donc, tout le monde est bien au courant de la situation. On essaie de faire en sorte qu'il y ait le moins d'impact possible. Donc, certains examens qui peuvent être faits sans contraste quand on pense que l'information qui va être obtenue va être suffisante. Puis, on a aussi réduit un petit peu les doses qu'on peut donner dans les examens afin d'avoir quand même des résultats qui sont optimaux. Le but étant naturellement d'éviter d'avoir un manque de produits dans nos hôpitaux. Donc, la situation, je dirais, est sous contrôle. L'activité a repris, comme je disais, dans l'usine à Shanghai et on a des livraisons annoncées, les quantités annoncées vont suivre. C'est juste qu'il y a quand même une certaine incertitude sur le timing. Donc, je sais qu'il y a certainement des cliniciens qui nous écoutent présentement. Et si vous n'avez pas reçu les courriels, on vous demande donc de prendre un instant de réflexion avant de prescrire un examen qui requiert du contraste. Est-ce que cet examen-là peut carrément attendre ou est-ce qu'il pourrait être remplacé par un autre examen qui pourrait être équivalent? Puis, je pense que nos radiologues sont aussi disponibles là, si jamais il y a des cas individuels qui doivent être discutés. So I'll take the next slide, please. I've written on this slide a few current priorities that concern not only the DPS, but the DPS in interaction with other the other clinical directorates of the hospital. One of them that I had been working on as a assistant DPS, but that I continue to care for, I would say, is bed flow and access to care. This is not only a DPS issue, it's a hospital issue. I chair a committee, that's the Patient Flow Committee, that looks at those issues. We also have bi-weekly coordination surge committees to address the current bed shortage at the MGH and at the Neuro, all due to staff shortage. So we are looking eventually at new positions to support the bed managers and the NRMs that are doing a great job trying to improve or to make bed flow something as easy as possible every day. So there are initiatives to have a medical coordinator in the emergency room to support the teams, and eventually someone that would do the same role, but at the hospital level, looking more at discharges and trying to plan complex discharges. Teams from the MUHC have been visiting other, I've written hospitals, but this is an old term, other CUSs to look at how they coordinate bed flow and what tools they use, be it dashboards, command centers, Power BI tools. So we have a lot of those tools already. at the MUHC, but we're trying to see how we can optimize their use and maybe create more tools that would help support our teams. So in terms of other priorities, obviously we're always discussing with our counterparts in the nursing directorate to look at reduction of services and trying to plan this as best as we can. We are, I think la direction des ressources humaines, des affaires juridiques travaille fort pour développer des plans pour aider avec les rétentions du personnel. On a travaillé beaucoup sur le recrutement. On parle aussi de garder nos gens, de les supporter et de voir là, ce qui peut être fait là, en ce sens. Donc, nous, on travaille de concert avec eux. I also participate in the deployment of the Comité de Vigie de l'Accès that's been put together by the PDGA, Martin Alfonso's office. Coming in the fall, this year actually is going to be in January 2023, is a year for accreditation. So the DQAPE is the directorate that's in charge of this process, but since this concerns quality, the whole hospital will be involved to different degrees. And as well, and maybe to prepare the next presentation for Dr. Rubin, the preparation for the 7th wave of COVID is also underway. So thank you.
We'll leave it to Dr. Rubin. You can go ahead, Earl.
Yeah, just going to try and share my screen. So hopefully you see my screen. So my name is Earl Rubin. I'm the Division Director in Pediatric Infectious Disease. Sorry, hopefully you still see me.
Dr. Rubin, we see your presentation well, but it's not in the slide mode.
Aha.
Slideshow mode.
Let's see if I can fix that.
Perfect, thank you.
All right, sorry about that. All right, so just starting off, what I'm going to do is kind of look at the province as a whole and then look at the MUHC and quickly just give an update. So starting off with the province, if we look at the evolution of the number of hospitalizations with the different waves, you can see that over the Christmas holidays and shortly thereafter was a big wave that seemed to come down only to go back up again in the spring. We are not out of it, but we are not at a peak. What's interesting is that you look, this is as of June 15th across the province, the breakdown of ages of those who are testing positive. And we're going to come back to the positivity rate and how we interpret that. But if you look starting at age 20 up to age 69, which is basically our workforce, you can see that it is almost 3/4 of the positive cases are in young adults, or like to consider 60-year-olds young. When we look at the reported number of tests and positivity rate, we know that as of December, testing was not readily available to the general population. And so we need to look at certain surrogate markers, whether it's wastewater, hospitalizations, and the ability for people to declare a test. As of June 18th, on one day, there were 7,500 samples that were tested. But what's interesting that most people do not know about is that there is a way to declare the self-home antigen test. Most people don't know that exists, and most people are not declaring it. And when people do declare it, when you look here just yesterday, there were only 356 declared, of which 88% were positive. So when you look at positivity rate, you have a whole bias built in of who is doing the tests and who is, even with the test, choosing to report it. So when we look at the positivity rate overall in Quebec, here it's in December, January, where screening wasn't available. So you are now testing a select population, either those who are at higher risk, those who are hospitalized, but in there are your asymptomatics who are going for surgery as well. And you can see that overall the positivity rate is in the 10% range or so. When you look at the overall number when testing was readily available, the positivity rate was obviously lower because we were doing many more tests. So when we look at just a snapshot in Quebec, there's your 7,500 that were tested. And of that, there were 844 new cases declared. This is as of yesterday. 1,000 hospitalizations, so it's not the over 2,000 or 2,500, which is really that panic level, but it is still significant with 12 new hospitalizations yesterday. What is interesting is when you look at what are the percentage of those who are admitted for COVID or because of COVID, rather than found to be COVID positive and being admitted for other reasons, so called the incidentalomas, only about 1/3 of those hospitalizations, whether it be in the intensive care or on the ward, are admitted for COVID-related reasons. But what is worrisome is the number of healthcare workers that are positive or missing work. So these are numbers from across the province. Just in the last 3 days, the number of healthcare workers who are absent for COVID-related reasons. So either acutely infected and still convalescing or at high risk that they could not work. So if we now move to MUHC wise, this is a graph that most people are familiar with. It goes over all the different waves. The yellow is the total number of inpatients, and you can see, I think we don't have to go over it, but you get a snapshot of the waves over Christmas. You can see, or shortly thereafter, how high that wave was with the appearance of Omicron. And again, in the spring, we are thankfully nowhere there, but when you look at the upswing, it is starting to tick up a little bit. When we look at the current situation at the MUHC, overall of confirmed positive admissions, there are 22. I won't go through all the numbers, but it's broken down here of which site and whether they are in the ICU or in the emergency room. But what's concerning always, especially from an infection control perspective, is what's going on in terms of outbreaks. And this slide just goes to show one area of concern currently at the MNH, where you have 12 healthcare workers since the start of this outbreak, which was only on June 2nd, who are infected, and when they are questioned, they attribute it to a workplace acquisition. So when we look now at the number of healthcare workers by week who are positive, you can see again, things were coming down. There was that huge number over Christmas and thereafter. Things were coming down, but you see that increase number. When you look at the colors on this graph, the blue turquoise is either from community or trips. A lot of the healthcare workers, a lot of the physicians have started to go back to conferences and are related to conference attendance. Travel is now much easier. More people are traveling, as we did not have the opportunity in the last 2 years. So just today at the MUHC, there are 160 healthcare workers who are absent because of COVID, an additional 34 who have been exposed and been permitted to work with the new algorithm, but need daily PCR testing with the ID Now before presenting, which is done in our test center. Our percent positivity rate of healthcare workers, if they are symptomatic and getting tested, more than 1/3 are symptomatic because of COVID. When you look at healthcare workers who are asymptomatic and getting tested because of exposure, the percent positivity rate is increasing from 1.5 to 2.5%. So all of this to say is that numbers, unfortunately, are ticking up. The last 2 Junes, our numbers were really plummeting. This June is different than the last 2 years. So we really need to continue practicing vigilance and to avoid coming to work, as Dr. Feller had said, if you have any symptoms at all. Where we get a lot of questions is the discordance between what we're doing here and what we're asking here and what's happening out in the community and the world almost at large. So some of those questions relate, or a lot of those questions relate to masking. For now, it is still mandatory on all sites that have clinical activities that masks continue to be worn. I do not foresee that going away in the near future. It certainly is the one thing that we do have to help in terms of mitigating transmission of not only COVID, but other respiratory viruses. However, there has been a change on the administrative sites where there are no patients and no clinical care, such as on Guy Street and DeCarry, that you do not need to wear a mask all the time, but you still should, if you are susceptible, you should still, if you cannot adequately distance. We really, we worry about a breach of service from clinical care, but all these people who are working on administrative sites are also doing their job, and we can't risk losing everybody. The next controversy we have is that, you can go to a restaurant and make a reservation without any restrictions, and people are not happy that we're still asking that people distance as much as possible when you are eating indoors with colleagues. At the Children's, we continue to ask that if there is a break room on a clinical unit and it's lunchtime, ideally only one person takes their mask off and eats and puts it back when the next person eats. It's really to try again to limit the transmission and not affect a whole clinical unit. So there are advantages to wearing masks. I think it really helps us and helps the people around us. We've had a number of other respiratory viruses, and in particular influenza, which is typically a wintertime virus and has appeared in late spring. So there are advantages to masks as much as we don't like them. It's, just because we had a global pandemic and we kind of reinforced hand hygiene, you don't need that global pandemic to realize how important it is to continue to wash your hands. And you can wash your hands there is no problem washing your hands hundreds of times per day. So Elizabeth Kubler-Ross had her stages of grief and dying, and there are the stages related to quarantine or really more to the pandemic, where we kind of started off all kind of statuesque like Mona Lisa and kind of ending off with raising a middle finger that we're all fed up. The other stages and before was the novelty of the fun of the novelty, and then just kind of starting to fall apart. And now we are just done. But the only thing that I can say is that as much as the world is fed up, we need to remain vigilant. And with that, I'm done.
Thank you very much, Dr. Rubin. Alors, j'inviterai tous les panélistes à ouvrir leur caméra, s'il vous plaît. Et pendant que vous le faites, je vais juste me permettre un petit commentaire. I never thought we'd see a middle finger in one of our presentations, but it illustrates our sick and tired we are of the situation. Very daring, Dr. Rubin. We continue to invite the over 700 participants who are currently present at the webinar to submit your question in the Q&A. Alors, si vous êtes parmi les plus de 700 personnes qui participent au webinaire aujourd'hui, on vous remercie et on vous invite à inscrire vos questions. Nous avons une vingtaine de minutes pour y répondre. Rachel, première question, s'il vous plaît.
Given the mask mandate fell for all indoor activity in Quebec, do you nevertheless have recommendations for healthcare workers, i.e. masking in public transport and grocery stores?
Dr. Rubin.
Yeah, so I don't think it's just for healthcare workers. I think that it is important for people to continue wearing masks if they are at increased risk should they get infected, whether it be for their own personal health, for the people who they live with in their own bubbles, and for the jobs that they do. So for healthcare workers, where we are still very much dependent on healthcare workers being present, I think it would be advisable. And I can tell you that my wife gives me a hard time every time we walk into a store. I put on the mask and it's nobody else is around, but including my wife who doesn't put it on, saying, you know, enough is enough. But I think we need to do our part.
Thank you, Dr. Rubin. Rachel, another question?
Yes, we have a couple of questions on the retention plan. So is the MUHC formulating a retention plan for employees given the staffing crisis? And could you give any details about retention strategies? Because people need hope.
Two good questions, and I will take this question. So the HR Directorate has done a literature review and exit interviews and is starting to see that with our ability to attract staff at the MUHC, which is very good compared to our partner institutions, we still have a lot of people leaving the organization every year. And we understand that in order for our teams to be at their full capacity, we will need to be better at maintaining our colleagues with us. So there's a project that is being developed. It's going to be the focus of a lot of work in the coming months. But we already know that one thing that is super important for people who are wondering, should I accept a job that's offered to me or should I stay, is how you're treated by your colleagues. So if there's a first message that is very important, is that whoever you meet during the day, a smile, a thank you if someone does something for you, especially if it's someone you haven't seen before, if it's someone new. Because the new folks feel that the very well-built teams have a great dynamic, but they're not easy to join. So if we start with that, I think we can make a first step. And obviously there'll be other measures that will be introduced in the coming months, because I repeat, this is going to be a huge focus of the work we're going to do for the rest of the year. So I don't know if our colleagues have more to say. We don't have additional details, but this is the main message. Ça vous va, mesdames des ressources humaines? Très bien. Prochaine question, Rachel.
There seems to be some confusion at the Allen Memorial about the masking. It says, we in psychiatry were told that masking is no longer mandatory at the AMI, which is an outpatient clinical site, not an administrative site. So I think we need to clarify the rules at the Allen Memorial when it comes to masking.
Madame Paquet.
Was the question in English or for English? Eh? So at the Allen Memorial, it falls under, there's a ministerial directive that says that in areas where you do not have inpatients or mixed clientele, where you only have outpatient psychiatry, the mask is not necessary for the patient. And actually, in practice, even for that clientele, we've never been really reinforcing mask at all times, unlike for maybe more other clientele. But now for employees as well, we've, like other environment, we've said we agreed with the ministerial directive that says that we do not need it. It was on the slide of Dr. Rubin. However, because of the risk of transmission between healthcare workers, we're still recommending it for healthcare workers. but it's not mandatory. We would highly recommend it, especially if one healthcare worker is immunosuppressed or has close contact with immunosuppressed people in their family. But it's not mandatory for that clientele, that specific environment.
Thank you, France. Rachel?
Do you have any sense of how long immunity lasts post a COVID positive test?
Dr. Rubin?
Yeah, so that's in evolution and varies with the immune escape depending on what variant is around. So there is the immunity with post-vaccine, there's immunity with having had COVID, and there is the immunity with the combination thereof of COVID and vaccines and the number of vaccines, and it really comes down to the timing. What we have, what we learned since February with the appearance of Omicron is that we are seeing people getting reinfected. It was common, the Omicron huge peak was, there was a significant number who had Delta or anywhere from the ancestral Alpha, Beta, Delta strains before. But there was an immunity that we believed was longer lasting, 6 months, they were talking about 9 months, and before Omicron, even a year. With Omicron, we're now seeing there was BA1, BA2, and now there's BA4 and BA5, that we are seeing people getting reinfected less than 12 weeks. So we're, at the present time, we're still saying that you have some immunity for up to 12 weeks, but we are getting cases at 10 weeks, 8 weeks, and there is even some reports in the States talking about 4 weeks. So it's not, basically bottom line is with the newer variants and immune escape, the duration of immunity, unfortunately, seems to be decreasing.
Thank you, Dr. Rubin. Rachel?
If our staff are attracted to the private sector, what would be the plan to better our working conditions to help retain and be competitive with the private sector?
Martine, je vais prendre celle-là.
Je vous en prie.
So this is a subject which is being discussed every time with the CEOs and the ministry. At the present moment, in many sectors, actually in all sectors, but in many sectors, it's really almost a crisis. I would mention information systems. I would mention administrative staffs, of course, nurses, respiratory therapists. So this is being discussed with the ministry, and I think there's a realization that we're going to have to keep up to par with the private sector. Otherwise, we're going to have serious consequences. So that's a discussion. Of course, the collective agreements were just signed with the unions. But at the same moment, I think there is a lot of anxiety at the government level concerning that topic. So we will continue discussions, and I can tell you that CEOs of the different institutions are really eager to bring up that point as often as they can.
Merci, Dr. Feller. Peut-être en complément d'information, peut-être que certains d'entre vous ne le savez pas, mais ce n'est pas l'établissement qui détermine le salaire des employés. Donc, ce n'est pas une décision locale, mais c'est, comme le dit Dr. Feller, une discussion qui doit avoir lieu aux tables de négociation et puis avec le Conseil du Trésor. Donc, c'est à suivre, en effet. Merci beaucoup. Rachel.
Est-ce que le 5100 de Maisonneuve fait partie d'un site administratif?
France, est-ce que tu peux répondre à ça?
Le 5100 de Maisonneuve, si je ne m'abuse, il y a des cliniques médicales, là, hein? C'est ça.
Oui.
Alors, malheureusement, là où il y a des patients, on préfère être encore plus attention pour protéger notre clientèle.
So we're asking people to wear their mask at all times, as if they were in one of our hospital sites. Merci beaucoup. Next question, Rachel.
When do we think the pediatric under 5 years old COVID vaccine will be available in Canada?
Dr. Rubin?
So just in the last few days in the States, the FDA gave approval for a 2-dose regimen for Moderna for 6 months to 5 years, and a 3-dose schedule for the Pfizer vaccine. I understand that it has been submitted to Health Canada for equivalent approval, but exactly when that will be rolled out, I'm not sure. But it should be forthcoming.
Thank you. We usually know immediately in the media, though, Dr. Rubin. It's so we can track that with the medias we trust. Rachel, a next question.
Avons-nous des nouvelles pour le retour du personnel suspendu?
Je crois comprendre qu'il est probablement question des personnes qui refusent la vaccination, qui ne peuvent pas se faire vacciner et qui ne veulent pas non plus se faire dépister 3 fois par semaine. C'est un des éléments qui est maintenu là, dans le dernier arrêté ministériel qui a été renouvelé. Donc, les personnes qui veulent ou peuvent pas se faire vacciner doivent se faire dépister 3 fois par semaine, c'est maintenu.
Merci, Madame Mayou, d'avoir compris la question sous la question. Merci. Rachel.
Is the Research Institute exempt from the mask mandate? Sorry, that just moved, and not at the clinical side of the hospital, while at the RI and not at the clinical side of the hospital. So if you're in the RI building, is that still, mask mandate still on?
Je vois que France a envie de répondre. In English this time, please.
Rule d'envie, no, mask is still required at the RI Institute because there are actually patients, and people circulate from the hospital side to the RI Institute. My office is on the RI side, and I travel on the other side.
It's considered to be on the same site as the hospital. Merci. Rachel?
How will the mask mandate be enforced within the MUHC without security screening at entrances?
So what we're doing is that we have a transition period by which we will not do the screening the way we're offering it now, but there are going to be a security agent making sure that people remember to put on their masks, and it's going to be a challenge for all of us who are no longer using them anywhere else. And then we'll see if we need to maintain security guards at door to enforce this mandatory measure. And there's also a whole communication planned with posters that we are going to see at the entrance of the units, asking people to wash their hands, obviously wear their mask, and not to enter if they have symptoms. Je sais pas, Alain ou France, s'il y a des informations additionnelles?
Ouais, peut-être en complément, on va donner des instructions aux gens dans les unités de soins s'ils observent un patient ou un membre de famille qui se présente sans masque, quoi faire. Donc, il va y avoir des instructions aussi données à nos équipes.
Merci, Alain. Une période de transition, on va regarder comment ça se passe et puis on va ajuster le tir au besoin. And of course, if the epidemiological situation worsens, well, we'll be ready to re-implement the filtrage aux portes. Next question, Rachel.
Are there cases of monkeypox at the MUHC? Is the isolation required contact droplet and or airborne?
Qui parmi nous a ces informations-là? France.
À ma connaissance, il n'y a pas de patients monkeypox ou en fait variole simienne en ce moment. Si ça devenait le cas, on a probablement eu des patients qui ont passé par l'urgence ou les cliniques et les précautions à mettre en place. Sorry, I forgot. Was it English or French? I don't even remember what.
English.
Okay, sorry. So precautions are airborne, contact droplet. And if there's no negative pressure room in the outpatient department, we'll make sure that the door is closed. The protocol is on the intranet. It's been posted.
And communicated to all teams.
So,
Dr. Rubin?
I was just going to jump in. So we, from an infection control perspective and with the evolving knowledge, we do know that you can amplify by PCR, finding it in the respiratory tract, and that's why we're concerned about airborne and doing all of that. However, what they are reporting out in the community is really much more significantly with skin-to-skin contact. And that is the predominant way of transmission. So I just don't want people worried that we're going to be jumping into another COVID with an airborne transmission, at least not at the present time.
Thank you, Dr. Rubin. As you've mentioned in your presentation, we need a break. We need a break. Prochaine question, s'il vous plaît, Rachel.
Dr. Rubin has said that if we test positive at home, we can still report it. How is that done?
Dr. Rubin?
Yeah, that's an excellent question. And in the 5 minutes before the presentation, I tried to go onto the website and be able to answer that, and I didn't find it. But there is a way, and I can look that up and get back to somebody to disseminate that.
So Dr. Rubin, what we can do is find the information and post it on the intranet, because if our community doesn't know how, it's going to be useful for many. So let's do it that way. Thank you very much. Rachel?
Are we monitoring the Omicron variants at the MUHC, especially regarding the BA2.12.1 present in North America versus the BA4 and BA5 variants in Europe, and as contagious? If you get BA2.12.1, are you protected against BA4 or 5? In this context of increasing infection rates, should we encourage healthcare professionals of getting a 4th booster sooner?
So there's a lot of questions in one question. In terms of what we're doing here at the MUHC, we're not doing criblage or sequencing. The LSPQ and the provincial lab, depending on what's going on with the epidemiology, will have sentinel kind of snapshots of what is actually circulating, but we're not doing that on a day-to-day basis here. So that's the first thing. In terms of immunity with the newer Omicron variants, with each one, there's a significant number of mutations that does not necessarily contribute to a durable immunity. And that's what we're just seeing in terms of the shorter duration. But there does seem to be some protection for a short protection. In terms of the last dose of the vaccine, that's a much more complicated question. For sure, I would highly recommend that anybody who personally is at increased risk of complicated disease, that they consider getting their 4th shot like anybody else, whether they're a healthcare worker or not. The efficacy of the vaccine is really strong in terms of protection against complicated disease, hospitalization, and death. Unfortunately, not as strong against protecting against infection.
Merci, Dr. Rubin. On arrive à la fin du webinaire. Merci aux gens qui ont participé. There are still many questions submitted in the Q&A. We will look at the questions and make sure that the information is available on the intranet. Thank you to the panelists. And Dr. Feller, pour le mot de la fin.
Ben, peut-être un petit peu plus qu'un mot de fin, c'est que j'ai regardé les questions. Il y en a plusieurs qui touchent la campagne de vaccination de la fin du mois d'août. Alors, hier, le ministère de la Santé et des Services sociaux a publié les balises de la campagne de vaccination qui aura lieu à la fin d'août. Ça s'adressera à toutes les personnes qui ont plus de 60 ans. De plus, les personnes de plus de 5 ans qui sont immunosupprimées, qui sont en dialyse, qui ont une maladie chronique, et les travailleurs de la santé, les femmes enceintes et les adultes habitant en région éloignée seront ciblés par cette campagne. So you will need at least 3 months between either your last dose or a confirmed case of COVID before getting the next dose of vaccine. There was a specific question as to whether or not our employees will be able to get the vaccine on the premises. The answer is yes. So we will be still screening for the disease and giving out the vaccines to our healthcare workers and probably some of our patients as well who are hospitalized starting at the end of August. Alors, ça répond aux questions. Il y en avait 2, 3 là, qui avaient des questions là-dessus. Écoutez, je vous remercie beaucoup. Il y a eu beaucoup de questions. Je pense qu'on n'a pas fait le webinaire pour rien, de façon évidente. Il y a des gens qui avaient besoin de précision, puis il y avait beaucoup de choses à préciser aussi. Alors, je vous souhaite une très bonne journée, un très bon été. Soyez prudents. Dr. Rubin a mentionné qu'on avait une petite recrudescence de cas. J'étais à un colloque jeudi dernier et j'ai eu un téléphone juste avant la conférence de la santé et sécurité au travail qui m'envoie me faire tester parce que j'ai été en contact avec quelqu'un lors du colloque qui est tombé malade. Alors, je m'en vais là, je vais me faire tester. Alors, soyez tous très prudents. Bonne journée. Au revoir.
Merci. Au revoir.